Welcome to this 1-hour lecture on dry eye. Dry eye, as you all know, is extremely common. I think there's a lot of misinformation out there, and what we're going to do today is share with you not only our clinical expertise, but we're going to share with you from the literature to bring you as close to on the cutting edge as is possible.
You know, it seems as we kind of introduced a lot of different lectures in dry eye, that it just gets more and more complicated in terms of what do you do and when do you do it, what do you use. And so we're going to really break it down and simplify it for you and give you at the end some new and exciting kind of information about treatments for dry eye. And so with that, regarding our financial disclosure, it's listed here. Nothing we say in the lecture is going to interfere or be biased toward these companies. You know, when you talk about dry eye, you can't help but mention the father of meibomian gland kind of research, and that's Dr. Donald Korb from Boston, Massachusetts. And he has really, for his whole career, studied and researched dry eye as it relates to the meibomian glands, and has really guided us as well as the world in the area of dry eye. So we want to kind of just mention him. Anytime there's a dry eye lecture, he should be mentioned.
That's true. It is interesting, from time to time, there are several authoritative supplements. You have to be very careful to see who is the sponsor of each supplement, because there will be inherent bias there. Thankfully, this is a non-industry supported supplement, and arrogantly, I guess we could say that this supplement is finally caught up with Melton and Thomas, because this is what we've been saying for years. But there's a couple of pertinent quotes that we need to share with you to sort of set the foundation for going forward here. Dry eye disease is indeed a heterogeneous disorder of the ocular surface in which the common denominator is inflammation. Topical corticosteroids play an important role in breaking the inflammatory cycle. And Ronnie, I think what's important here is repeated short-term pulse therapy has produced a disease-free state for more than 1 year in a study of patients with Sjogren's syndrome. How would you describe to our audience what is short-term pulse therapy?
Well, there's actually two phases. The first phase is a patient comes in symptomatic with dry eye. They're symptomatic because they have ocular surface inflammation. And so you really have to treat the inflammation long enough to get it under control. And then once you get it under control, you have to then do maintenance therapy to keep it under control. And yet, even with that, patients are going to break through their dry eye, their ocular surface is going to get inflamed again. And once it gets inflamed again, to the point that they're symptomatic enough, then they start the anti-inflammatory therapy 2 to 4 times daily for a week to get things back under control. So the initial control of the inflammation takes more than a week, but then the pulse dosing of it for a week or two periodically throughout the year, that's what we mean by pulse dosing.
Okay, just sort of if they have a flare up, you can just sort of knock it back down over the span of about a week, and then sort of kind of defibrillate the flare up and get it back under control.
Correct.
And keeping on here, it says when meibomian gland functions correctly, the lipids secreted reduce ocular surface water evaporation and prevent dry eye. So when these glands are reduced, absent, or dysfunctional, the impact on the ocular surface can be, as you all well know, it can be rather immense. And treatment of dry eye disease is based on minimizing inflammation and optimizing various components of the tear film. This same article goes on to say inflammation is one of the major targets in treating dry eye disease, And Ronnie, as you just alluded to, breaking the cycle of inflammation is crucial to improving symptoms. All patients with dry eye disease deserve a trial of anti-inflammatory therapy at some point during their therapy. I think it'd be right up front. And it says here, quoting again, corticosteroids are one of the most effective and rapid therapies available for suppressing inflammation on the ocular surface.
I think it depends on how severe their symptoms are as they come in. If they're mild, then you may not need to get the inflammation under control up front. It just may mean lipid-based artificial tears are all you need. If it's more moderate or severe, their symptoms are greater, then I think it's going to take the steroids to get the inflammation under control.
Yeah, and this last bullet about the fish oils, the jury is still out. I mean, I don't know there's any consensus opinion of the virtue of fish oils, but yeah, we'll stay tuned about that.
I think as clinicians, most of us feel that they are helpful and recommended for patients. I sure do.
I thought this was an interesting article from Ocular Surgery News. This is a dry eye guru. His quote is, "The original and still most effective treatment for pretty much all things dry eye is topical steroids." He goes on to say, "I predict that 2019 is year one in the age of steroids and dry eye disease." Well, oh buddy, we've been saying this now for 20 years. Mm-hmm. Then he goes, and then here's the thing. It's not about signs, it's about symptoms. Let's just verify that with 3 different quotes from the literature. Dry eye disease remains a largely symptomatic diagnosis without a single diagnostic test. In other words, you can diagnose dry eye on the telephone. This cornea service expert at Harvard says, "I typically place more emphasis on symptoms than signs when managing any patient with dry eye." And then most recently from Ocular Surgery News, said, "Sadly, it is still common for an obviously symptomatic patient to be sloughed off if objective data does not seem to indicate severe disease. In the end, it is important for us to start treatment for all patients with symptoms." It's all about symptoms.
There are different forms of the loteprednol drop that's available now. For a long time, there was just one company that made the loteprednol, but now there are several companies that are in on the act, and there's a generic version of the loteprednol. So there's different forms, different strengths, ranging from 0.25 to 1% concentrations of the loteprednol. There's no question that the Lotemax, this is an example of Lotemax SM of Bosch and Long, that you have to use 4 times daily for a couple of weeks, and then twice daily for a couple of weeks would be my initial form of therapy for most of the patients that are symptomatic with their dry eye.
And this is going back to that dry eye expert in Ocular Surgery News. He said, "As I predicted last year, steroids were big for all kinds of indications related to the ocular surface. Once dry eye disease is diagnosed, the American College of Cataract and Refractive Surgeons protocol encourages aggressive, rapid-acting treatment that includes the use of steroids on the ocular surface. All kinds of loteprednol should see a bump in prescriptions written because of this." And I think that's powerful. I mean, there's a big time organization advocating for the institution of steroids right up front. And I think they're right on the money.
Yeah, it just took them a long time to get there. Yeah, we've known this for a long time and have been, as you had mentioned, doing this for years and years.
So again, we go back to the literature. It says, given the importance of inflammation, dry eye pathogenesis, various anti-inflammatory agents were used to treat this syndrome. In particular, there is a type 1 level of evidence on corticosteroids efficacy. Among these, loteprednol was effective in reducing signs and symptoms of dry eye. And again, note that we're quoting you directly from the literature that you can peruse yourself.
Going along with the loteprednol theme, it's interesting that loteprednol first came out in 1988 and
1990.
Not 1998, not 88, 1998, and yet the official FDA approval of using loteprednol for specifically for dry eye just happened in October of 2020. And that was with this kind of newer version of the loteprednol, 0.25% concentration by Kala Pharmaceuticals, Asuvis. So it's the official first approved steroid for dry eye therapy.
So does approval mean a lot to you?
But it hasn't, since 1998.
Right. There are some of you out there that approval is important to you. For us, it makes no difference. Just the key is to use steroids for dry eye. That's the bottom line.
And again, the approval was for use up to 2 weeks, 4 times daily, and then to be repulsed as needed over time. And again, I would, from a clinician standpoint, really kind of argue that if you've got a patient with moderate to severe dry eye, 2 weeks of the therapy is not going to be enough. They're going to need it probably at least a month of the 4 times daily.
Right. But if they're going to repulse them, I just go QID for a week. That gets everybody back on track. And that's the simplicity of repulsing on an as needed basis. I did think this was interesting, Ronnie. It says, quote, the next to the bottom bullet there, adverse events and IOP increases were comparable to those with vehicle. And that should not be a surprise to anyone listening to this lecture. It comes in a box like this. Notice the white cap in the picture there in the middle. That's the safety seal. You just twist that off, and then what the patient will use on a daily basis is they'll unscrew the pink cap. So the white cap is just the seal that's tossed in the trash can. And so the picture on the right is what the patient would use.
It is interesting in the fact that this product is going to come in an 8.3 ml bottle. So it's going to have quite a bit in it, compared to the 5 ml bottle that most of the drops come in. And so that makes it a little unique. And even that 8.3 ml bottle size is filled with what the company says more than 8.3 ml.
So that one bottle should last a patient a full year if they repulse as needed.
It's going to last them a long time, I would think. Is that not a concern?
No.
That they're going to be steroid dependent, and they're going to get glaucoma secondary to having a bigger bottle of this? No. Perfectly fine.
This was in I think it was a January issue of 2021 review of optometry. And so we've parlayed that into this lecture. It's really interesting to see kind of what it is that we collectively do. Obviously, we're in deep love with fluorescein. Look at the second, tear film breakup time. Absolutely simple, easy, and highly useful. Looking at the blink, and Ronnie, you're really big on assessing the blink of patients.
Mm-hmm.
And then I think we fall off the log. I have 0 use for dry eye questionnaires. Just ask the patient, how do your eyes feel? I mean, this is not hard. Keep this simple.
There's several different questionnaires that are out there. Some are extensive, a lot of questions. Some are shorter, like the speed survey. But my dry eye questionnaire is, okay, patient on a scale of 1 to 10, 10 being the worst, 0 being your eyes feel great. How have your eyes felt over the last couple of months? And what's the worst they felt over the last couple of months? And they'll give you an answer. And most of the time, if they're in for a dry eye problem, it'll be between a 5 and a 10. And often it's a 10, commonly a 7 to an 8. Those are patients that really have a lot of inflammation to their ocular surface and need help in getting it under control with the loteprednol drops. So that's my dry eye questionnaire. See them back after you treat them for a month or so, and ask them again. Okay, you were a 7 or an 8. Now what are you? If they still say a 7 or an 8, then you got a tougher patient on your hands.
Right, but Ronnie's right on the money. I mean, that's the simplicity and the quantitative proper way to assess your health of the patient.
Yeah, I just saw a little blurb from one of the dry eye expert gurus, basically saying that he was developing a new dry eye assessment kind of survey, and what it was a scale of 1 to 10, 10 being bad and 0 being none. I wonder where they got that.
Yeah, I wonder. The experts are catching up with little old Ronnie over there.
Well, they are.
Good.
Yeah.
Good. But that's interesting. Then kind of similarly, I think if we look at the top, 2 or 3, again, I have no use for the questionnaires, excuse me, but mybography would be good. Every OD's office in time should have a mybographer. I think that's so important to assess the meibomian glands.
If you've got a dry eye center of excellence and that's all you do, and you're spending your time just totally dedicated to dry eye, then some of the ones further down, may complement or supplement what you're doing.
Waste of time.
But it's the first 3 first 2 that really are what's going to help you. And clinicians really see that. I mean, that's from clinicians. They're doing the survey.
But all these are relatively worthless relative to assessing for their symptoms. Look at here are the symptoms.
Dry eye questionnaire. Your questionnaire is okay. How bad is it?
Right.
And
they'll tell you.
Yeah, that's your questionnaire.
It says here, what percentage of your dry eye patients do you use each of the following methods to manage their condition? And I think, Ronnie, it's pretty fair that artificial tears are a reasonable, with or without concurrent use of loteprednol. I think we're big on educating about screen time, and it's almost like asking people to quit smoking. How are we going to cause them to alter their lifestyle? So I think we're probably dreaming there. But look at that 3rd bullet, at-home eyelid hygiene. And there's many ways to do that. And we're going to share with you a new technological breakthrough toward the end of this lecture. But that number 3, I think, is very important, at-home eyelid hygiene. Now, this is from Dr. Korb. So when you hear the word Korb, you pay attention. Hypothetically, early and frequent debridement of the line of marks, that is the mucocutaneous junction of the lower eyelid, could prevent or delay the cascade of increased osmolarity, tissue desiccation, and ultimately inflammation and tissue damage simply because of mechanical barriers to oil entering the tear film. This single scraping of the lower eyelid improved comfort and improved meibomian gland function. There are significant benefits to a single scraping of the lower eyelid in an office visit. We'll show you a picture here of how we use the golf club spud or even the Blef X. But this again, Dr. Korb says in the future, well, the future is now. The health and maintenance of the mucocutaneous junction and keratinized lid margin may be considered integral to routine eye care. This shift in our modus operandi will cause improvements in our observation skills and also the willingness to incorporate novel techniques such as scraping across the top of the lower eyelid in our clinical practice. I'm telling you, try this, do it on 3 or 4 patients. You will find very quickly this is a cool and helpful procedure.
And this has evolved into, for example, the Blef X, which is like the dental burr that has the tip on it, like a Q-tip that just whirls around, and will kind of do the same sort of scraping or cleansing of the lid margins to get them hopefully ready for heat to open them up. So
But the key is just like everything in life, B follows A, C follows B. You need to at least prepare the top of the eyelid to get maximum benefit from heat therapy.
Absolutely.
This is from Survey of Ophthalmology back about 6-7 years ago. This is important as doctors. We need to understand the pathophysiology. Hyperkeratinization of the orifice and ductal epithelium leading to meibomian gland obstruction is considered the primary cause of meibomian gland disease. This directly results in decreased meibomian lipids on the ocular surface, resulting in an unstable tear film and evaporative dry eye conditions. Further, the increased internal pressure from the obstruction leads to atrophic changes in squamous metaplasia within the meibomian acini, causing a secondary hyposecretion. And what we're trying to do is not have a hyposecretion, but have a physiological secretion.
So we've kind of moved from getting the ocular surface inflammation under control to now attacking the lids and the oil glands to try to get them working better.
Yes.
So we can get the ocular surface protected better.
Right.
Okay. And, one of the things, the ultimate thing that emerged to do that was the lipoflow, okay, which is the thermal pulsation therapy, heat therapy, to kind of get the meibomian glands opened up and squeezed out so they can kind of regain function again. Many years ago, I had this done in one eye, and I went for a year with this done in my right eye only, my right lids, and that eye felt better for the whole year.
Placebo effect.
It doesn't matter what it was.
Yeah, it worked. You felt better.
It worked. And then a year later, I had it done in both eyes.
So you had to save up money to where you could afford to have both.
The technology is pretty sophisticated. It's not an inexpensive kind of procedure. The probes are expensive. Initially it costs quite a bit. The cost has been cut in half.
It's still expensive.
Since its origin, but it's definitely something that can benefit a lot of patients.
Yeah, the problem is it's just pretty much prohibitively expensive for many practices.
Right. But the literature really supports this type therapy, as being very, very helpful at reducing patients' dry eye symptoms. To where kind of once you do that, then over a 12-month period of time, the patient's symptoms are low to non-existent for up to a year.
Yep.
So, and that's without kind of supplemental therapy. Although just because you do this procedure doesn't mean that you still don't need artificial tears and warm compresses and blinking exercises and omega-3s.
Well, I mean, dry eye is not a one-trick pony. It's a multifaceted approach, and
For sure.
And we're all aware of that.
So, I was able to actually be involved in a study where we did lipoflow on contact lens patients that were actually decreased wearing time. They had decreased wearing time. And in doing lipoflow in those patients, their wear time increased dramatically. They were able to wear their contacts
Well, I mean, a good
much
tear
more
film.
successfully.
I mean, a good tear film is important for contact lens wear. We're trying to get to that. Yeah,
Right.
Absolutely.
Yeah.
Now, there are three major in-office procedures. We've talked about lipoflow. There's Ilux. There's tear care. So focused heat application followed by doctor-delivered meibomian gland expression is a critical intervention for moderate to advanced dry eye disease. Tear care is an in-office procedure where heat strips are strategically placed over the eyelids to achieve optimum liquefaction of the meibum. Once liquefaction is quickly achieved, The doctor then properly expresses the meibum contents, thus allowing for a more physiological meibum to be produced. And we go back to the dental analogy where you go in, you see a dental hygienist, they achieve a deep cleaning of your gingival and periodontal tissues. And the same thing here would be analogous to the meibomian glands. And then this is an example of the tear care device, and we'll show you a picture of that in vivo. And you can see these little strips are heat to a perfect optimum level. And then after that, this is done in office, and the doctor gently expresses the meibum contents, which hopefully sort of defibrillates the function, and then you get a more physiological meibum that is produced.
So we kind of talked about the LipiFlow, the tear care. A third kind of procedure to really work on the oil glands in the lids is the Ilux. Actually, my last patient yesterday, I did the Ilux procedure on, and in doing that, I found patients get almost an immediate benefit. They, it's not a week or two later, and the whole session is kind of like a yoga, a massage session, where it really is not that uncomfortable for patients, and the kind of debris that's excavated out of the oil glands is amazing sometimes.
Oh yeah,
just how clogged up they really are, and so it's definitely something that will help to at least clean out the oil glands and hopefully be able to get them functioning better from then on.
right. If you'll notice, we haven't spoken much at all about the lacrimal glands, because in a relative sense, the lacrimal glands play a very minimal role in dry eyes. The meibomian glands, that's the star of the show, is pretty evident from this lecture.
Yeah, but yet, with dry eye, in these procedures, which really help to get the oil glands cleaned out to where you can get a fresh start, you really have to kind of follow that up with heat. You've got to have the patients use kind of heat
Well, sure.
long term. And heat really to the lids is hard for the patients to comply with. I mean, it really is a tough thing. The washcloth under warm water, squeeze it out, lay it over your lids for 10 to 15 minutes is how long you really should be doing this. And yet, who's going to do that 10 to 15 minutes? Yeah, they're going to have to reheat it 10 times,
right.
Over that period of time. So there needs to be a better way to do that. And lo and behold, we definitely have a better way now to be able to apply the heat.
Yeah, this is really right out of the starting gate, a very new, highly sophisticated technology called Evertears. And, just because you go to the dentist and get your teeth cleaned, you still have to floss and brush your teeth on a regular basis to maintain what's been established in the office. And this Evertears technology, these little rascals heat up quick. I mean, just a matter of seconds, you're already up to cruising altitude. And then you just need to leave them on the lids for 2 or 3 minutes, and then it's moist and you can scrub and then clean off the debris. It's just a wonderful new technology.
Yeah, it's has potential to revolutionize this whole heating aspects of things. The heat, to me, after you get your oil glands kind of cleaned out, is probably the most critical thing down the road to keep the dryness under control.
Sure.
That and blinking exercises. And Don Korb really helped us realize that, the warm compress and blinking exercises where you have the patient relax their eyes closed and squeeze, open, relax them closed, squeeze, open, and do that every 5 seconds for a minute. at least 4 times daily. If they work on a computer, they need to do it, 8 to 10 times daily.
But the blinking exercise would be greatly potentiated if you had already heated the meibomian glands to begin with.
No question about it.
Yeah.
It's going to just make it work a lot better.
They're little oval pads, and you just kind of just twist them a couple of times to get the chemical to activate. And again, the heat comes up 2 or 3 seconds, very rapid onset. So we go back to the review of optometry, and what I want to look at here, it says, what percentage of your dry eye patients do you use each of the following methods to manage their condition? We've already shown you first, it was artificial tears. I think getting people to alter their screen time is about as successful as getting them to stop smoking. But look at number 3, at-home lid hygiene. That's what we're speaking of here. Once we've got the ball rolling, the patient needs to be coached on how to keep the ball rolling. And it looks like we're doing that, but we have a newer, better way now, which is wonderful, because all these other, like you discussed, the hot washcloth, that's really kind of barbaric, antiquated approach.
Yeah, I think as this new technology kind of emerges and becomes readily available, it's just going to be the way to go.
And it's still disappointing to me you have topical cyclosporin before topical steroid. Hopefully, with the information we're sharing with you here, you'll realize that loteprednol needs to be the star of the show in suppressing inflammation.
Well, it's the thing you use to get the patient's symptoms under control, to get their ocular surface settled down, and then you go after the lids with heat, and you complement that with long-term heat, kind of to keep the oil glands functioning and working.
Absolutely true. So it says here, the ineffectiveness of today's treatments in unblocking the meibomian glands and maintaining good tear flow and homeostasis is the problem to be addressed for dry eye and meibomian gland. We've talked already about debriding the mucocutaneous junction. And then after that, when you apply the heat, then that's going to further enable the heating to be very function enhancing as far as getting the meibomian glands to begin to work more normally. And this device, these Evertears, can deliver the heat therapy and finally provide a therapy to help address the real meibomian gland trouble. And you can see here, looks like there it is, I think 2 or 3 seconds, but they're showing there maybe 15 seconds to get the heat level up to optimum therapeutic levels, and then maintain it for that 2, 3, 4, 5 minutes that you or the patient cares to use.
Yeah, it was once thought that you had to heat the lids up to that 40 degrees centigrade and do that for 12 minutes or for a long, long time.
No.
But that has been disproven, and it, as you can see in this kind of graph here, that if you can get the heat to 38 to 40 degrees centimeter, Celsius, and keep it there for just a couple of minutes, then you're going to achieve what you need to get the oil glands loose.
Yeah, absolutely. So the benefits of home-based warm soaks. We already know that heat application is a well-established therapeutic intervention, but all varieties of these heat applications somehow fall short of optimum. So there's an evolving need to facilitate this therapeutically beneficial intervention, and the Evertears technology is self-contained, rapid onset, heat-maintaining, moist pad that patients can use to help maintaining meibomian gland function in the privacy of their homes. And we've shared before, it's sort of analogous to daily flossing and brushing to maintain dental and here oral health. It's available over the counter, manufactured by a company called Thermomedics. I thought this was interesting. March 25, 2021, again, out of Ocular Surgery News, their quote is that heat application should be accomplished to the lid margins once or twice a day. And so, I mean, the literature continues to support heat therapy is essential intervention for maintaining good dry eye control.
Right. Marguerite McDonald, who I think all of us know, kind of commented on innovation. Our understanding of dry eye and MGD is advanced, yet compliance remains our greatest impediment on successful patient outcomes. At-home therapy options are somewhat helpful, but inconvenient. Dry eye patients need precise heat and lid hygiene in one simple, convenient, and affordable OTC option. So she's kind of partnered up with the ThermaMedX on an innovation solution to this problem, which is the EverTears.
So it's interesting. You could use TearCare, Ilux, or LipiFlow, and so this dual approach may be the optimum in patient care for dry eye disease. Excuse me. First, the patient is treated in office with either of those three, followed by meibomian gland expression by the optometrist. And then second, post-procedural at-home maintenance via the EverTears heating system can extend and maximize the benefits of the doctor-delivered in-office treatment. This is analogous to the dental hygiene followed by daily flossing and brushing, as we've discussed. And whatever can be done to help restore and maintain meibomian gland function can be foundational to optimum care of patients with meibomian gland disease. And this is sort of the approach that Ron and I have used now for 20 years. If a patient comes in to see you and they're symptomatic or Ronnie, they have a level 5 or greater, we need to do something of substantial nature to help them. Obviously, we need to use a lipid-based tear. Aqueous-based tears are minimally effective. So a lipid-based tear used frequently. Then we use loteprednol, QID for 2 weeks and then BID for 2 more weeks. And once that month is behind us, we can stop the loteprednol. This ocular surface inflammation is quieted, it's gone. But Ronnie, but patients, if they keep doing the right things, then even there, they'll still break through every 3, 4, 5 months. And then you have to hit them again with a pulse dose of loteprednol, QID for a week, just to get them back on track. And we've done this on hundreds upon hundreds of patients. And the reason we do it, it's real simple. It works. So, the majority of patients can get their dry eye symptoms under control with the month's worth of the steroid eye drops. Excuse me. And yet, along with that, goes the artificial tears, the lipid-based artificial tears that they need to use. And as you back down on the steroid drops, then you add in the lipid-based artificial tears more. As you stop the steroid drops, then they need to be doing lipid-based artificial tears, depending on their symptoms, 2 to 8 times a day, but at least 2 to 4 times daily, first thing in the morning and before they go to bed are critical times, because that's when most patients have the driest eyes, either early in the morning or late at night. But during the day, they also need complementary lipid-based artificial tears. They need warm compresses, and we have discovered a way to provide the warm compresses in 2 minutes per eye, as opposed to 10, 15-minute session where you got to reheat the washcloth 5 times, and then it may and may not help. Right. If we're doing that and patients are breaking through a lot and quickly after you do the month's worth of the steroid and continue the kind of maintenance therapy, then you can look for more aggressive alternative therapies that's out there, such as the cyclosporin, the Xiidra, there's a new biologics
category that's out on the market that seems to be working very well for dry eye in order to help that you could do a little more long-term therapy with. Punctal plugs, are of course something that if patients get under control and they quickly break through again, or they have them use artificial tears more frequently, you can have them use the or you can insert punctal plugs, particularly inferiorly, that can help this whole process.
Yeah, I think we all egregiously underutilize punctal plugs. I think we need to really rethink that in our own heart and order some, keep them in your office and apply them to enhance patient care.
This I give out 10 times a day at least in my practice. And it's going to be modified as we go along. Where we recommend a lipid-based artificial tear, you can fill in the ones that you want, the warm compresses where you do that. I've got even a newer one of these that talk about the heating kind of gel packs or beads that you can buy and throw in the microwave to heat for 10 to 15 seconds. It stays heated for 10 to 15 minutes. But
you need to get this up to date because this is really antiquated at this point.
Well, it is, and it's going to be replaced with the new kind of ever tears, because I just see that as being a way to heat the lids kind of in a very clinical way and to do it in a way that patients are going to be a lot more compliant.
Yeah.
As well as the blinking exercises, I think that's critical in the fish oil supplements. It doesn't have to be fish oil. It can be krill oil. It can be, whatever you've researched and found to be the best omega-3 supplement for the patient.
Mm-hmm.
As I had mentioned, we've got as therapy to try to keep the patient under better control long term. If you're doing the maintenance therapy, that's going to probably be as effective, if not more effective, than a cyclosporin more long term, or even a Xiidra long term.
Right. I mean, those two drugs in sequel all take a major backseat to loteprednol. I mean, don't be swayed by marketing, be swayed by science. Again, going back, ocular surgery news, they always seem to be so on the cutting edge, and we enjoy reading that. It's interesting. Another great tip. I thought this was pretty funny, actually, Ronnie. A short tapering course of Lotemax is helpful in initiating therapy with either of these other drugs. The steroid gives extremely fast, same-day relief from dry eye symptoms and usually masks the stinging that can accompany the initiation of therapy with either agent. I usually give Lotemax 4 times a day for 2 weeks and twice a day for 2 weeks. Well, we've been doing this, Ronnie, for years and years and years.
Correct.
So if the steroid suppresses the inflammation, there is no need for Restasis or Xiidra. The loteprednol does it all. And it's the least expensive intervention that's out there. So even if you pay $200 for a bottle, it'll last you for a year.
And we had briefly mentioned the biologic category, which is the newer kind of approved dry eye therapy that's out on the market now. That I think probably when it's all said and done is going to outperform the other approved kind of therapies for dry eye, FDA approved therapies for dry eye in prescription form. Other than the loteprednol, of course. And, there's a company that makes the biologics and that's Regenerise. And it comes in two different strengths, kind of a Regenerize and a Regenerize Light. The Regenerize original is the stronger. It's more expensive, has to be refrigerated, so it's a little bit less patient friendly. But also, if you have broken down corneas, a bullous keratopathy that really is just non-healing, I have found it very helpful to use the stronger version of the Regenerize to really help heal that cornea.
See, I'd like to see a study, but my gut feeling is this might be as good or better than an amniotic membrane. I don't know that, but it certainly has that ability, I think. But look at their website, mydryeyes.com, or .org rather. Just check it out. I think this is something that's going to play a larger and larger role going forward.
Yeah,
Just love to see some studies.
Correct. And I probably have 100 patients on this therapy, and I think it's definitely a good alternative to the Restasis and Xiidra that's out there.
Right. Do keep in mind that these fish oil supplements are rather large. And for those folks, and you need to ask everyone, do you have trouble swallowing horse pills? Because these are substantially large. And for those that don't, there are a lot of liquid fish oil supplements. What I used for years, I've stopped using fish oil myself for my dry eyes, and they don't seem to be any worse. But this Core Omega it's an orange sherbet flavored liquid that's really very palatable. And for those folks that can't swallow large pills, then think about these liquid alternatives.
The one thing that has happened with the COVID era is education online, and particularly in the school systems. And so with that has come a lot of pediatric patients coming in with dry eye complaints. They're sitting, staring at a computer 6 to 8 hours a day, and then they're playing video games 6 or 8 hours a day. And so particularly the guys. And so with that has come a lot of patients coming in with dry eye problems in the pediatric population. We just did not see that at one time, and now it's almost epidemic in proportion.
Oh yeah, I mean, these screens are going to kill us all. The bottom bullet, the evaporative dry eye disease associated with smartphone or any kind of screen use is a lifestyle disease. And we need to kind of think about it in that greater picture.
Yeah, and we have all these patients coming in, video games on, world off. That pretty much sums this guy up.
It does. Yeah.
And his eyes are dry. They bother him all the time. Unfortunately, he's like a 4-diopter hyperope, and so which doesn't help his staring at the computer all day long deal. I just saw a patient this past week, and so he was wearing this T-shirt, and mom brought him in because his eyes are bothering him. They're dry. They're irritated. And he plays video games probably 6 or 8 hours a day. But he was wearing this Julius Erving shirt.
Right.
And I said, I bet you don't know who Julius Erving is.
Yeah.
No, he has no clue who Julius Erving is. Well, that just kind of sums it up. I mean, they're in a different world.
They are.
So I gave him the history of who Julius Erving was.
And you wonder why you get behind.
Well, you got to have something.
Oh, God. And I'm prescribing stronger glasses for you, and I recommend a neck brace for your smartphone use. That's kind of humorous now. That may be the real deal in 5, 10, 15 years.
Oh, that's for sure. He's got an antiquated eye chart, doesn't he?
Yeah.
Kids and screens.
Yeah, I mean, I'm telling you, I think we're losing a lot of our childhood education to this obsession with screens, particularly the video games and so forth. Okay, I think that we have given you the best that we know as a literature-based, clinically experienced approach to dry eye. It's not that hard, but we need to think through the different approaches. And especially as new technologies come along, we need to really rethink our habits and embrace new therapeutic and different types of approaches to help patients with dry eye disease.
Yeah, keep in mind that patients present with dry eye symptoms all the time, and even your routine eye exams. You try to find out if their eyes are dry, if they're symptomatic with that as part of their routine eye exam, and you're going to uncover a lot of patients that are symptomatic that just are coming in for a pair of glasses. They're just getting an update on their glasses.
Sure.
Yet, I'm pretty aggressive at trying to work on their dry eye symptoms and signs if that's part of what you find in their routine eye exam. So you got to get the inflammation under control, and then the maintenance therapy to keep it under control is critical also. And this new heat therapy that is hopefully going to become commonplace is going to be an exciting technological innovation.
So just bottom line, take care of your patients in a manner in which you would like to be cared for. And with that, we thank you for your time, and we hope this has been helpful to you in the care of your patients.
Thanks.